to introduce all of you to Dr. Michael Young. He is a neurosurgeon in Oak Lawn, and he received his medical degree from Nova Southeastern University, College of Osteopathic Medicine, and has been in practice for 6 to 10 years. He received his fellowship at the Operative and Endovascular Neurovascular Surgery, Beth Israel Deaconess Medical Center at Harvard Medical School. And his residency was completed in neurological surgery at Advocate Berman Medical Center. His hospital affiliation is Advocate Christ Medical Center, and his subspecialty is cerebrovascular neurosurgery. So we are very privileged to have Dr. Young here with us today, and you can take it.
All right. Thank you, Susan, for the invitation to speak here tonight, and to the entire stroke team for helping set this up and all the support, obviously, that you always provide. I appreciate everybody that's here in person and obviously online as well. This will be recorded, so anybody can come back and listen to it in the future. So as Susan said, yeah, I'm board certified neurosurgeon with fellowship training in cerebrovascular neurosurgery and neuroendovascular surgery. Basically what that means is I treat stroke, all kinds of stroke, ischemic stroke and hemorrhagic stroke, and we'll talk about that. But today's talk, I really wanted to increase awareness to the community and spread the importance of recognizing stroke early on. And so we'll be talking about BEFAST. BEFAST is an acronym that stands for, we'll talk about what it means, but it also means be fast in reacting. It means stroke is very important and to react in a timely manner. So when I first heard this, I thought it was a little cliche, but it's actually based in data. Time is brain. So every minute that there is an ischemic stroke ongoing, where there's a blockage of blood flow to the brain, 1.9 million neurons die. And millions more synapses, the connections between those neurons, die as well. So I want to backtrack and talk a little bit about the history of stroke. So stroke was obviously it's been around forever. There's been patients that have had sudden collapses. There's been patients that have deterioration over time, and we've known about that historically, but we haven't really had a treatment for it until recently. So it was always focused on rehabilitation, and then later was on prevention in terms of modifying risk factors. In the 1990s, there was finally a somewhat of a treatment that came around, and that was a medication given through the IV called a clot-busting drug, or thrombolysis. Since the 1990s, though, we haven't really had anything to treat stroke with besides an IV medication until about 10 years ago, when we finally had a breakthrough in research and data. We knew that there was ways to go in through the artery and take the clot out of the brain, but we didn't have any data to back it up that it actually worked. Now, if you talk to a lot of people who have been around this field for a while, they say anecdotally, yeah, we knew it worked, but there was nothing that as a medical community we could go and sit in front of you all or sit in front of some of these national meetings and say, look, it's better than just giving the drug and then seeing how they do, until 2015. And that's when within that year, 5 trials came out. These are the pivotal trials that proved that going in there and using different techniques to take the clot out, called a thrombectomy, is actually beneficial. And so these are the 5 trials, and we won't get too much into data tonight, but basically they all showed statistical significance, meaning they worked from a data standpoint to show a benefit of intervention through thrombectomy with the IV clot-busting drug. So now that we have a treatment where we can actually go in and take something out, how do we get more patients access to it? And this is the major problem. There's only about 10% of stroke victims that actually receive treatment. And a lot of these challenges include, even now, when this is 10 years later, public awareness, EMS awareness, or EMS responsiveness, or EMS availability, access to the medical care and equipment. We're here in the Chicagoland area in an urban center, so we have many, we have a lot of resources around, a lot of hospitals around, But in some of the non-urban centers, there's not as much access to medical care and equipment. How do we improve that? And then obviously a little bit what we talked about, there was slow progress in the scientific advancements and treatments up until recently. Some of the other barriers we face in getting patients access to stroke treatment is about 89% or that 10% of stroke patients have a delay in seeking treatment. And the most common reasons are, oh, they think the symptoms will get better or that nothing can be done. Up to 75% of patients call a friend or a family member instead of calling 911 right away. And the patients that are farthest away from comprehensive stroke centers, those are the centers that do the thrombectomy and have full coverage for all types of stroke, have the lowest rate of treatment futility. And even in geographically defined areas like this, only 1 in 5 patients gets timely treatment. What are some of the other barriers? Some of the emergency physicians. Many emergency physicians don't want to give IV thrombolytics or even recommend thrombectomy because they still don't believe in or aren't up to date on some of the data that's been advancing in this field. One report said only 48% of ED docs feel that the thrombolytic, the clot busting drug, is effective. That same study showed that 32% found that it was not effective and 20% were concerned about the bleeding risk. There's also significant knowledge gaps in our new indications for stroke, which is a whole other talk in and of itself. But as we've proven benefit that stroke works and is beneficial to patients, there's now areas where if a patient has a low stroke scale or that they're out of the original window, which was less than 6 hours, we now have plenty of data to support that up to 24 hours and even greater with the right imaging criteria are patients that show benefit to having this treatment. But there's still a gap there. There's a lot of ED physicians and even communities that don't believe that that data exists. Some of the other barriers that exist are hospital concerns, training of physicians, training of nurses and techs and EMS personnel to be able to take care of these stroke patients. Availability of CT scanners and CT techs 24/7 that know how to perform a CTA is a barrier. Availability of rapid 16-gauge IV access. Once again, in a major urban environment, not as much for us, but when you get out to some of these rural areas, these are real concerns. And the need for rapid interpretation of what a CT scan or CTA shows, that's the imaging that these patients get on arrival, with radiologists on call. And how do they interpret it quickly enough? If a scan is done, but it's not read for another 3 hours, that's all that time where there's neurons that are dying, and there's not enough radiologists in some of these places to read these scans. So how do we fix some of these barriers? So the pre-hospital stroke recognition. One of the things we do, which is what we're doing tonight, is public stroke awareness campaigns and EMS utilization. We go out and we have community centers where we talk to people like you, and we try to spread the word of acting quickly with stroke. Same with EMS. We go talk to them about bringing patients to the closest comprehensive stroke center, the closest place where the thrombectomy can be performed. There's the underdiagnosis of an elbow. That's a large vessel occlusion. That means a clot that can be taken out. So we're starting to, as a community, train EMS on recognizing what symptoms in a patient look like a stroke or a large vessel occlusion. Having teleneurology, which means neurologists that are available via basically Zoom or Teams type chatting, video conferencing, or teleconferencing to look at a patient, evaluate them, give them a stroke scale and say, this is what you need to do. These neurologists can be anywhere across the country, but they're rapidly available at centers that don't have a neurologist on board 24/7. And then improvement in ordering the vascular imaging for anything that looks like a stroke. I will say I've seen at Christ, we've gotten a lot better at that. Anything that looks like it could be a potential stroke is getting a CT scan, a CTA, and a lot of times a CT perfusion to see if there's an indication for them to receive treatment. Some of the physical barriers that exist are that geographic access that I talked about in these rural areas. So how do we get over that? There's the bypass model, meaning either helicopters or ambulances just take them as soon as they see a patient that has any signs of a stroke, instead of going to the closest hospital, bypassing that hospital and going to a comprehensive stroke center or thrombectomy capable center. And then also increasing the total number of thrombectomy capable centers or comprehensive stroke centers, meaning getting hospitals more availability to access to perform these procedures. And then also, as this has become a newer field, there's still an insufficient number of trained neurointerventionalists. So how do we improve that? We train more. So there's a lot more training programs that are popping up. There's 3 different pathways to be a neurointerventionalist. You can be a neurosurgeon like myself and then do a fellowship. You can be a neurologist and then do 2 fellowships and be an interventional neurologist. Or you could be a radiologist and do 2 fellowships and be an interventional neuroradiologist. All of these different pathways allow for us to have more people that are available to treat stroke. Some of the financial barriers that exist. It costs a lot of money to build a thrombectomy suite. It costs a lot of money to build a thrombectomy program. There's a lot of resources, a lot of support, a lot of staff that you need. So how do we improve that? We increase reimbursement to incentivize hospitals to create these programs. We improve reimbursement for stroke procedures and for diagnosing stroke and for taking care of patients with stroke. And then thrombectomy procedural costs. To do the procedure has gotten a lot cheaper, but it still costs. And how do we improve that? We reduce device costs and we use aspiration technique, which has been shown to be a lower cost when possible. That's kind of a talk that's a little bit more outside of the scope of this talk, but basically reducing costs when we can. So this was a study that looks at, this is on the bottom and the horizontal line, it's basically patient outcomes and how can they improve patient and what's the numbers for patient outcomes. It says MRS 0 to 2. 0 is very good and it goes up to 6. 6 is the patient's no longer with us. But they showed in this study that all this time that passed by just little delays resulted in a worse outcome over time. And this is basically before the patient gets even diagnosed with a stroke. So some of the delays include the family recognizes the symptoms, but they're unaware that it's a stroke. Or the family waits to call EMS. EMS doesn't identify the symptoms that it could be a large vessel occlusion that could need a thrombectomy, and they don't transport to the nearest thrombectomy capable center. Delay at the thrombectomy capable, delay in the door in to door out time at the at the non-thrombectomy capable center. Then the delay in the neurologist or teleneurologist in ordering the correct imaging. Then the delay in the radiologist confirming that it is a large vessel occlusion or a clot that needs to be taken out. Then the transport to that to that comprehensive stroke center, thrombectomy capable center. And then if they need another image to determine if they're outside the window. All these delays exist every single day, and we have to improve them and figure out ways to improve the time that it takes, because it's shown to have the longer time, the worse patients do. So how do we react? Well, you have to know the signs of stroke and remember the mnemonic BEFAST, which stands for balance, eyes, face, arms, speech, and last one is time. Time is the most important to act. So what do we mean by balance? What may you see your loved one experience? They may be unable to walk with significant coordination. They may be stumbling or unable to walk straight. They may feel faint or lightheaded or like the room is spinning. What you may notice is that they're wobbling around or they're grabbing onto an object or they're tripping over nothing. Unsteady movements, like it looks like they have motion sickness or like they're drunk without having any alcohol. Vision changes. What they may experience is blurred vision or trouble in eyesight in one or both eyes. What you may see is they start squinting their eyes or they might not be able to read. Face, that means facial droop or severe headache. So what they might experience is one side of their face is droopy and they may have discomfort on their scalp or their head in one area. What you may notice is that when you ask them to smile, they can't correctly elevate both sides of their smile, and you can see that facial droop. Or if they have that headache, they may be touching their head or grasping onto their head. A stands for arms, which means weakness. They might not be able to have the same strength that they usually have on one side of their arm. And what you might notice is they want to lay down or they don't want to use that arm. And in terms of arm, they could also have numbness. They may have tingling feeling. And what you would see them doing is constantly touching or massaging or trying to shake out the numb areas. S stands for speech, or they're having trouble speaking. They're unable to speak, or they have slurred speech. You may see them have sentences that don't make sense, or it's like a word salad, and difficulty having a conversation. They could also have confusion, where they're unable to understand what is happening, or they don't feel well or feel thrown off when they're speaking. And you may see them look puzzled or confused or raising their eyebrows or shaking their head to normal conversations that would make sense for them. And T is time. It means it's time to call 911. It's not time to call another family member. It's not time to call somebody else for medical advice. It's time to call 911 and get them into the nearest, into the hands of EMS. So who's at most risk for a stroke? It can really happen to anyone, but there's a number of risk factors that can increase it. The risk factors that we can't change are age. About 1 out of 5 people who have a stroke are actually under 55. Race. African Americans, Hispanics, Asian, and Pacific Islanders have a higher risk of stroke than people of other races. Gender. More women have stroke than men, and more women die from a stroke every year than breast cancer. Family history. You're at a higher risk of having a stroke if your family member has had a stroke. Things you can control include high blood pressure, atrial fibrillation, high cholesterol, smoking, diabetes, poor circulation, lack of physical activity, and obesity. So the big thing is to get the facts on stroke, to educate yourself, to attend talks like this, to read literature that's available, but to understand that this is something that it's the equivalent of a heart attack. It is a brain attack. It occurs when the blood vessels in the brain are not getting oxygen because there's a blockage, or the brain is not getting oxygen because there's a blockage in the blood vessels. And any of this impairs that oxygen, and like we talked about earlier, that brain, those neurons die very quickly when they don't have oxygen. That's why it is imperative to, whenever you see any of these symptoms, to act immediately and contact EMS. This is just a video to kind of overshow. This is something that we made in my fellowship to kind of show the community a little bit what it exactly looks like at a workflow of a stroke. So how does this actually happen? So I'll fast forward here a bit. But basically, once we get the page from the outside hospital, the neurology team that they've identified a stroke, the neurology team then activates the stroke, and then they call the neurointerventional team. The EMS then directly transports the patient to our endovascular suite so we can then plan to perform our procedure. So this is the EMS bringing the patient directly in from the outside hospital, or we then quickly get them ready on our table. This is the endovascular suite, where we use very sophisticated imaging like this, where we inject dye and we can see the blood vessels of the brain. This is a patient that has a left-sided occlusion. There's a territory that's missing there, and we prep our devices and get ready to go. So in this case, we used what's called a stent retriever and an aspiration catheter. These are just techniques, but basically they're different devices that exist out there that help get the clot out of the brain. That's actually the clot that was taken out of this patient. And then we do final imaging that shows that all the blood vessels to the brain are open. Now, just because we've opened all the blood vessels to the brain, we can't fix any of that damage that was done before. So that's why we always evaluate the patient in the ICU and make sure that they don't have any worsening exam. And then we get an MRI afterwards. In this patient, the MRI shows us how bad the stroke was before the patient got to the hospital. And this patient did incredible and actually was able to go home in a few days. Oh, I need to do that. stop playing.
Yeah, that's okay.
So these are some more examples. These are things that we've done recently at Advocate Christ. So this is a patient that came in with a history of atrial fibrillation, like we talked about. They were on a blood thinning medication, but they had stopped it for a procedure that they needed to have done. They came in with a left facial droop, dysarthria, which means slurring of speech, left hemiparesis, which means weakness of the left side of their body, and their stroke scale was 8. They were last seen normal 6 hours prior. And you can see here in the red circles, there's a blockage there. This was correctly identified by the family. As soon as they noticed it, they brought him into, this was an outside hospital. The outside hospital quickly evaluated them, got a CT head and a CTA that showed this blockage, and they transferred him to Christ immediately, where we saw this on our first picture. These pictures are called angiograms. Like I said, it's where we inject dye under X-ray imaging. And then we went after this clot. Let's see. So this is just us coming up with our catheter. We go past the area of where the clot is, and then we actually just perform suction on the catheter to remove the clot. And this is the follow-up. After that clot is removed, you can see that area that was circled in red before is now filled in with these arteries. And this patient had an MRI, which is shown here, which, like I said, maybe outside the scope, but there was really no stroke that they had. And this patient went home in 2 days because the family recognized it quickly, because the EMS reacted quickly, because the outside hospital reacted quickly, and because we were able to get the clot out quickly. So, like I talked about briefly earlier, there's 2 different types of stroke. Right now, we mostly focused on ischemic stroke, which is that blockage. And the reason why is that's the majority of stroke. It's anywhere between 85 to 90% of all strokes. However, there is another type of stroke, which is a hemorrhagic stroke, which is a bleeding type of stroke, which happens when there's an artery that ruptures or a vein that ruptures that can cause swelling and pressure and damage to the brain. And this is I love this illustration because it shows basically all the different types of lesions that can cause hemorrhagic stroke. But at Advocate Christ, since we are a comprehensive stroke center, we treat all of the types of hemorrhagic stroke as well. And the most common ones of these are aneurysms, arteriovenous malformations, dural arteriovenous fistulas, and cavernomas. And tonight I want to really focus on aneurysms because this is another disease in a stroke disease that is underdiagnosed and undertreated as well. 1 in 50 patients and 1 in 50 people in the United States have a brain aneurysm. And the big concern with aneurysms is they can bleed. And when they bleed, about a third of patients do okay, get back to where they were. A third of patients have some significant morbidity and disability, and a third of patients don't make it. So it's important to diagnose these and treat these when applicable before they bleed. And just before we close and take some questions, I want to just briefly finish on the different ways that we treat aneurysms. They're difficult to diagnose. I often have patients say, how do I know I have an aneurysm? Well, most times you don't know you have an aneurysm unless it ruptures. But a lot of times as we have medical advances and imaging techniques that have advanced, we started to scan people's heads more and more, and we're able to see them unruptured. So a patient may get a scan for headaches or for dizziness, or we're in a traumatic accident. A lot of those times then we find this aneurysm or these aneurysms unruptured. And it's important to seek treatment as soon as that is diagnosed. Some aneurysms don't need treatment, and that's a whole nother talk. Some aneurysms need treatment soon. But the importance is to get into a medical provider that deals with aneurysms as soon as you get that diagnosis. Some of the risk factors for bleeding include, and for aneurysm formation include smoking history, the family history of aneurysms. Those are the two biggest. Gender, females have a higher prevalence of aneurysms than males do. Being hypertensive or having a history of high blood pressure has a higher risk of having an aneurysm. Ethnicity, certain ethnic groups have higher risks of having an aneurysm. Patients that have multiple aneurysms are at a higher risk of bleeding of those aneurysms. And then in terms of bleeding, the irregularity of an aneurysm. We talk about sometimes it looks like a smooth, like a balloon. Those aneurysms we've studied that have shown maybe have a less bleeding risk than one that has multiple bumps on it and lumps on it. Those are a little bit more concerning for bleeding. So how do we treat these? Well, historically, there was always open treatment, which means craniotomy, which is an incision in the head, an opening of the skull, and then placing a clip on an aneurysm. Even more historically, there's bypass and trapping of the aneurysm. So when a clip can't be placed, you can put two clips and trap the aneurysm, then actually take an artery from a different territory and connect it to the artery that would be missing by trapping that aneurysm. We've had a lot of advancements in endovascular surgery since the 1990s, and there's multiple different ways to treat aneurysms by going through the artery in either the groin or the wrist. And we can go up there and place little small coils. We can also place a stent and then small coils, or use a balloon to help us keep the small coils inside the aneurysm. There's been major advances in stent staying outside the aneurysm and just putting a stent called a flow diverter in the last 10 to 15 years. And by using that device, we actually allow the blood to stay in the normal artery, to not go into the aneurysm anymore, and then to actually become one with the normal vessel. And over time, the aneurysm shrinks. And this has really become the most common way we treat unruptured aneurysms now. And then some of the newer technologies that are coming out now are called intrasaccular devices. So instead of going into the aneurysm and placing multiple coils, and we can actually go in and just put one device that kind of acts like it occludes the inflow of blood into the aneurysm, and so that will allow that to shrink off and close off. So as we go to close here, I just wanted to show a few examples of the ways that we treat aneurysms at Advocate Christ. And this is an example of an aneurysm that was found here to be in what's called the anterior communicating artery. And we went in here, you can see that large bubble in the middle of the screen there. And then we went in here with small wires and catheters, and actually were able to get into the aneurysm. This is a small wire going into it. And then what we do is we advance a small catheter over the wire. And then through that catheter, we can then place several small coils to occlude the aneurysm. And these are the coils going in. And at the end, that aneurysm is no longer filling. So that's one way we treat aneurysms. Another way is we do clipping, which is the open surgery where we actually go in and place a clip across the aneurysm. This here is a what's called the left ICA bifurcation aneurysm, but you can see there on the left side of the screen, or the left side of the screen, there's kind of that bubble with some real white in it. That's some calcium. And this patient, because of certain factors, was deemed a better candidate for clipping. So here we are entering the skull and working not within the brain, but working within the areas where the blood vessels and the nerves live. This is the nerve that goes to the eye, and this is the artery, the internal carotid artery. And I'll just fast forward a little bit here. We then can place these other clips that are called temporary clips that occlude the blood flow coming to the aneurysm so that it's less risky. And then we can place a permanent clip across the neck of the aneurysm. And you can see here that will completely close off the blood flow to that aneurysm and protect it from the risk of ever bleeding again. Then we check all the vessels are normal and nothing is occluded by the clip. This is a dye that we can inject through the IV while we're in surgery that could actually show us the blood flow through the normal arteries and also show us that there's no blood flow into the aneurysm. Another way we can treat aneurysms is stent coiling. So this was a patient that came to Advocate Christ who had severe headaches and confusion, and this is an unruptured aneurysm, but they correctly got a scan, and it showed this very large aneurysm that needed more than just coils, because the concern is the coils can actually come out of the aneurysm that's so big like this and actually go into the normal vessel. So we were able to put a stent in the normal vessel. The stent is open, it allows blood flow to go through it, and then we were able to coil it off, as the picture on the left shows here. These are just 3D renderings where we check at the before and after to make sure that all of the aneurysm is filled and all that metallic structure is coils filling it. One of the, like I talked about, the newer advances in aneurysm treatment is flow diversion, meaning we put a stent in the normal vessel that goes away from the aneurysm, not into the aneurysm, but goes through the normal outflow of the aneurysm. And we can do all of this through the artery in the groin or sometimes the wrist, and using wires and catheters, we deploy a stent. And after we do this, we start to see that aneurysm disappearing. That's a sign that it's going to clot off. Typically with flow diversion, it takes, we wait to do another test for about a year because it takes time for that aneurysm to shrink down and thrombose off. And then lastly, one of the newer devices that we use is these, like I said, these intrasaccular devices where we go into the aneurysm with a single device. This was a patient that came in with the worst headaches of their life, but luckily on their CT scan, they did not bleed. But when you hear of patients that are starting to have new headaches that are way out of proportion to any headaches they've ever had before, they've never had headaches, there is the concern that maybe there's changes going on in that aneurysm, and that needs to be treated sooner rather than later. So this was a very irregular shaped aneurysm that has this kind of finger-like projection coming off of it, not that smooth bubble. And so we knew we needed to treat this sooner rather than later. And so just due to certain characteristics, we performed one of these intrasaccular devices. We were able to place that in the aneurysm, and you start to see the aneurysm actually starting to clot off already as soon as we put that device in. All that's what we call stasis, meaning that filling that stays there is the aneurysm starting to clot off. And the picture on the left that shows the device itself, what it looks like, and the dark area is actually contrast that got trapped in there. So when we inject it, and that contrast is the blood. So we know that blood is being trapped there, and that part of the aneurysm, the scariest part of the aneurysm, will now clot off. So the stroke is ischemic and hemorrhagic, but both are imperative to act, to be fast, to get your loved ones in front of EMS, to be vigilant about it, to not wait for symptoms to resolve or to think that symptoms are to minimize symptoms, because we can now treat all these types of strokes in a very emergent manner. And especially in this at our center and a lot of centers in the Chicagoland area, we can do this and correct if the diagnosis is allowed to be presented to us. So with that, I will conclude. I want to thank everyone for being here and for joining online, and I'm happy to answer any questions or take any comments.
Young, I just want to say, I'm Kate, I'm the stroke program manager, I work with you, but to the group, I just want to say that 80% of strokes are preventable. And we know that, and that's why Dr. Young is out here talking to you today. We want to try and prevent that. And how we do that is by knowing and treating those risk factors that Dr. Young did talk about. So if you have that high blood pressure, that high cholesterol, making sure that you're treating that so that hopefully we can prevent that stroke from occurring. So just something to keep in mind.
Yeah, great point, Kate. No questions online?
Did you want to say something about? Oh, I did.
Oh,
Yeah.
Any questions?
No. Thank you.
Thank you very much.
Yeah.
Thank you.
Thank you guys.
and it was very Christmas